Welcome to Savage Minds. I'm your host, Julian Vigo. Today's guest is Joanna Moncrieff, a professor of critical and social psychiatry at University College London and an honorary consultant psychiatrist at the North East London Foundation Trust. She has led and contributed to large governmental funded research projects evaluating psychiatric drugs and is the author of several books including Chemically Imbalanced, The Making and Unmaking of the Serotonin Myth, A Straight-Talking Introduction to Psychiatric Drugs, Second Edition, The Bitterest Pills, and The Myth of the Chemical Cure, as well as many academic papers. I welcome Joanna Moncrieff to Savage Minds. I want to thank you for coming on the show because your work is very important to common myths, I think, that have been disseminated both within popular culture, popular publications, but also within your own field and the field of psychology. Your recent work focuses heavily on deconstructing the biological model of mental illness, notably exploring the serotonin myth of depression, the real efficacy of SSRIs compared to placebos, and the severe, often minimized effects of antidepressant withdrawal. In 2022, you co-authored a historic umbrella review in molecular psychiatry that fundamentally dismantled the long-held chemical imbalance theory, sparking a massive global conversation about what depression actually is and how we can treat it. As a consultant psychiatrist and a professor at the University College London and the author of Chemically Imbalanced, I'd like to know if we could start off with, given how deeply entrenched this biological narrative is, what first compelled you to challenge it so publicly?
So I've been a psychiatrist since the 1990s, so for over 3 decades now. And it's never seemed to me that this idea that mental illness is essentially the same as physical illness was compelling. It seems to me that mental illness is a very different sort of situation. It's a situation that's primarily defined by people's behaviour and expressions, by what people do and what people say, rather than something that's going on in people's bodies, which is the definition or how we all understand a physical illness or disease to consist of. So I suppose that was the motivation, just this feeling that we're dealing with very different things when we think about what we call mental illness. Of course, that term is misleading because most people think of illness as being predominantly a physical state of affairs. And I'm saying that mental illness is not something that originates in the body, but it is a situation that involves people behaving in ways that they find burdensome or inconvenient or distressing, or that other people find burdensome or sometimes threatening.
And is the role in psychiatry fundamentally to look at how medicine of all sorts, not just necessarily pharmaceutical medicine, can be used to, if not cure, then mitigate some of the symptoms of mental illness? Or maybe could you explain what the role of the psychiatrist is?
So currently, I think the role of the psychiatrist is modeled on the role of other doctors. So the idea is that psychiatrists will diagnose the underlying cause of someone's difficulties and then apply a treatment that targets that cause. And this is where the idea of the chemical imbalance comes in, because there was this idea that depression and other emotional problems were caused by, and other mental health problems were caused by imbalances or deficiencies of certain chemicals in the brain, and that these could be targeted by specific drugs that helped to rectify this imbalance, helped to normalize the chemistry of the brain. And of course, this idea wasn't proven, but this is the template that I believe really structured the role of the psychiatrist. Of course, psychiatrists do many other things, because you simply cannot ignore the fact that when people have emotional and behavioural problems, they are very often reacting to things that are going on in their environment, the way they are feeling, what they say and how they behave is not just the meaningless result of a physical mechanism. It is a meaningful response of a person to a situation. So, of course, psychiatrists also take that into account and try and work out what someone is reacting to and what can be done about that, and whether, and can recommend or indeed give people psychological therapy and other interventions to try and address their situation. But as I say, I think the primary template for the practice of psychiatry is this template that's been borrowed from general medicine, which is this idea that what the doctor does, the psychiatrist in this situation, is diagnose an underlying condition and then apply a treatment that targets that condition. And everything that I've been writing for many years, long before the serotonin paper came out, is suggesting that that whole model is not supported by evidence, is mistaken, and that there are other ways of thinking about what physical treatments might be doing when they're given to people with mental health problems.
Do you have other examples in psychiatric history when similar situations emerged, when there was a belief that X treatment worked, but in fact it was anything but helpful, or it wasn't actually a treatment?
So there was quite a well-known treatment for people diagnosed with schizophrenia back in the early part of the 20th century. It came in probably in the late 1930s and 1940s, and it was widely used in Europe, probably a bit less widely used in the US. And what it consisted of was administering insulin, strong doses of insulin, to people who are diagnosed with schizophrenia in order to put them into a coma, a hypoglycemic coma, a coma caused by lacking glucose, by reducing the levels of glucose in the body. And people were kept in these comas for several hours at a time, and then they were woken up dramatically by giving them a shot of glucose, which would sort of wake them suddenly out of this coma. And insulin coma therapy, as it was called, was thought to be an effective treatment for schizophrenia. But not only that, it was thought to be a treatment that was not just symptomatic, didn't just sort of dull the symptoms or sedate people. It was thought to be a treatment that targeted the underlying pathology of schizophrenia. It came in at a time when there was a lot of interest in hormones, and hormones were being synthesized for the first time. So insulin was first made in the laboratory in the 1920s, for example. So psychiatry sort of got onto that hormone bandwagon and suggested that psychiatric conditions might be caused by hormonal deficiencies or abnormalities. And that's where the idea that insulin coma therapy might be effective came from. Now, what's really interesting about this story, and a student of mine did a very interesting project on it a couple of years ago. What's really interesting about this story is that although it was a very widely recognized and accepted treatment, it was written up in great detail in all the textbooks of psychiatry. There were hundreds, maybe thousands of papers published on it, mostly, saying what a great thing it was. Even despite that, that general acclaim that it was greeted with within the psychiatric profession, there were psychiatrists, some quite prominent psychiatrists, who were skeptical who was saying, actually, I don't think this works. There's no real basis for believing that it works. And there were even some saying that if it does work, it's working by numbing people, by dumbing them down, by zonking them out for a bit so that they temporarily become so confused, because the whole process of the coma and when people woke up from the coma, they were really quite confused for a while. So these people were suggesting that it was the confusion that temporarily replaced people's symptoms of schizophrenia that gave the appearance that this procedure was being helpful. So there is a model. It's happened before in psychiatry. There are other examples as well. And as I say, it's not just that a widely recognized and accepted treatment was discovered to be ineffective. It is actually the case that there were different views at the time within the profession, as there are now, about the likely mechanisms and benefits of a widely used treatment.
And I'm wondering about the drug-centered model, because I'm in the country of certain psychiatric reformers, one of whom is viewed controversially. I'm thinking of Ugo Cerletti's electric shock therapy. And what has changed in the world, I guess, since then, where the drug-centered model versus the heavily physical Italian innovations like Cerletti's electric shock therapy?
Franco Basaglia and other psychiatrists who were very much pushing in the other direction of trying to give patients more rights, take down sort of oppressive asylum structures, and get away from this medicalizing model of psychiatry and physical interventions. So you have a very interesting history in Italy of different strands in the history of psychiatry. But ECT, along with insulin coma therapy, ECT was the other big pillar of a turn towards a physical view of mental health problems and an idea that they could be properly treated by physical interventions, not just suppressed, because people were already had long been treated with lots of sedative drugs, which were regarded basically as chemical restraints and not thought to be anything sophisticated or targeted in any way. But when you get ECT introduced and insulin coma therapy, there develops the idea that there are these targeted treatments for mental health problems, even though, as I say, insulin coma therapy is eventually proven and generally accepted to be useless, not only useless, but very harmful. And we still use ECT, but I think you can make exactly the same arguments about ECT that were made about insulin coma therapy, that what you're doing is basically giving the brain an insult, or an injury of some sort, and that the symptoms of that, temporarily, the confusion, the memory loss, sometimes the euphoria that goes along with a brain injury, temporarily obscure the underlying mental health problem. But those procedures, ECT and insulin coma therapy, very much laid the groundwork for the introduction of modern drug treatments and for the idea that what these drug treatments do is not just act as chemical restraints, but act as targeted treatments that target and reverse the underlying physical mechanisms that generate the symptoms of mental health problems, as they're called in that model. So that's what I have called in my writing the disease-centered model of drug action, the idea that drugs are targeting an underlying disease or an underlying physical mechanism that generates symptoms. And I've also proposed that that's not the only way of understanding what drugs are doing. There is an alternative way of understanding them that I have called the drug-centered model. And that's really going back to that old idea that drugs were acting as chemical restraints or suppressants, or or altering people's mental states in one way or another, depending on the characteristics of the drug, but altering normal mental states, not reversing underlying abnormal physical mechanisms.
Indeed, I've written quite a bit about Basaglia and the Basaglia law, because Italy was the first country in the world to completely abolish traditional mental asylums. Do you see your current work deconstructing the biological model as a continuation of that kind of structural critique?
In part, yes. I would say that myself and other colleagues in the critical psychiatry field at the moment are all working to try and strengthen a non-pathologizing, non-illness-based idea of mental health problems that I think makes it clear that these are human problems of human interactions that need to be helped and supported in different ways, that it's not about tweaking people's brains. So I think that's, I mean, times have changed, and, we're no longer in the asylum era, so the issue is no longer whether you're treated in a long-term institution or not, because there are almost none of those left. Although, in fact, they are left. They're just small and private and hidden away, or at least in this country, that's what they are. But the question is no longer whether institutional care is the sort of standard correct treatment for approach to people. It's more how do we conceptualize what's going on in the name of treatment, and how might that be changed? How might that be different?
Since your study in 2022, what has been the most surprising reaction from the mainstream psychiatric community to your work?
Well, first of all, it was surprising to me that the psychiatric community took so much notice and got so upset about it. And that's because prior to that paper, I had mostly been ignored. I think my work had been ignored partly because it's very difficult to actually challenge the drug-centered model of drug action. Unless you're going to say that these drugs don't affect the brain, and of course, everyone agrees they do affect the brain, you have to acknowledge that they are changing something about the brain, and therefore they will be changing our normal mental states, and therefore those changes might interact with people's underlying difficulties, or what we call symptoms, and therefore that they'll be having that, working in that drug-centered way. So it's difficult to challenge my ideas on drug action, and I think people have therefore most psychiatrists have taken the tack of just ignoring them. But the trouble is, the serotonin paper got so much publicity and media coverage that it couldn't be ignored. So that was the most surprising aspect of the reaction, that it really generated so much reaction from the psychiatric profession. The other that was surprising and very disappointing, I think, was how entirely defensive that reaction was. Instead of acknowledging the findings and acknowledging that this might mean that psychiatrists, and indeed medicine in general, because of course we know that many antidepressants are prescribed by general practitioners, need to take a different approach, need to stop telling patients or implying to patients that there is something wrong with their brain, and need to acknowledge more that depression and other emotional states are meaningful reactions to situations, and need to think differently about antidepressants and what they're doing. Instead of that, they just buckled down in a very defensive way, saying, okay, well, of course we knew the serotonin theory wasn't supportive, it's far too simplistic, but we know that depression is a physical condition, they said. We just don't know what that physical basis is. And then they threw out lots of sort of speculations about possible physical mechanisms that might or might not involve serotonin, but might be causes of depression. and this is one of the problems. The serotonin theory of depression came to be believed because there was just so much written about it. There were so many papers speculating that serotonin might be involved in depression, so many information leaflets and internet sites generated by the pharmaceutical industry, but also by professional organizations, suggesting that depression might be due to chemical imbalances, might be due to underlying brain mechanisms. If you throw out enough of that speculation, people will start to believe that it's true. People will start to believe, that these are not just speculations, but are proven facts. And so you could see that happening again after the publication of our paper, that people were just throwing lots of speculations around about possible mechanisms of action that had a biological basis, in order to try and persuade the public to go on believing that depression is a biological condition, that it has biological causes.
Why do you think then, given that many psychiatrists responded to your report saying that they already knew the chemical imbalance theory was oversimplified, why do you think that narrative was still actively promoted to patients?
I think it was promoted because I think psychiatrists want patients and the public to go on believing that depression is a biological condition. I think they want that because that legitimizes the role of the psychiatrist in the treatment of depression and other common emotional problems. If it was admitted that actually we have no evidence for any specific biological mechanism underpinning these problems, which of course is not to say that there aren't things going on in the brain when you're depressed or anxious or whatever. It's not to make a sort of non-materialist point of view point. It's just to say that we haven't pinned down any specific mechanisms such that we can consider these conditions to be diseases, in the same sense that, say, Parkinson's disease is a disease that is the legitimate territory of the doctor. It's been really important for psychiatrists to get people to go on believing that depression and other emotional and behavioural problems are proper diseases, in order to justify their role as medically qualified practitioners in the treatment of people with these problems. And I think there are other ways of thinking about the role that medically qualified practitioners can have in helping people with emotional problems, because as I've said in my work on drug action, I think there are situations when the use of some drugs can be helpful. If someone is really acutely manic or acutely psychotic, then giving them something that, first of all, reduces their arousal and allows them to sleep and be calmer is helpful. So prescribing some sort of sedative agent. In people who are really psychotic and really preoccupied with hallucinations and delusional beliefs, giving a drug like an antipsychotic that seems to be able to slow down thinking processes and reduce people's emotional investment in those ideas, it can be useful. So I think there is a role for these medical treatments in some circumscribed situations that we refer to as mental illness or mental disorder. But I'm challenging the basic medical model that these situations are medical conditions, are caused by bodily mechanisms in the same way that something like Parkinson's disease is caused by. And I think that makes psychiatrists feel very insecure, because it suggests that we need far fewer psychiatrists. It suggests that actually the predominant approach to people who are suffering from emotional and behavioural problems should be a social and psychological approach rather than a medical one. So I think that's the bottom line. Of course, the pharmaceutical industry, I should mention them as well, play a large role in this. the pharmaceutical industry obviously want to sell drugs to people who have emotional and behavioural problems. And although they were, up until the late 1980s, they were quite happy selling people drugs that they branded quite openly as being sedatives and tranquilizers, that whole way of marketing drugs came into disrepute in the 1980s because it became clear that the current blockbuster drugs for the treatment of emotional problems, which were then the benzodiazepines, largely being prescribed to people who were diagnosed with anxiety, caused physical dependence and sometimes some really severe withdrawal symptoms and difficulties. So that crisis over benzodiazepine withdrawal brought that model of giving people sedatives or tranquilizers into disrepute, and the pharmaceutical industry had to find a new way of marketing their drugs for emotional problems. And that's when they came up with the idea of depression being a chemical imbalance that was rectified by their new range of antidepressant drugs, the SSRIs. So the pharmaceutical industry have been very much responsible for publicizing and popularizing this view that our emotional and emotional problems are down to our brain chemistry and are therefore medical problems that should be treated in a medical way.
In the 1990s, I was teaching at New York University, and I had many students, and I noticed many of my friends and people, hearing people speak on the train, that it seemed like every other person was on Prozac. I became very concerned about this because living in the United States as an American, I started to notice the augmentation of publicity on the subway. I didn't own a TV then, but whenever I would be at people's homes, let's say for Thanksgiving or Christmas, and they had the TV on, I noticed that it was wall-to-wall advertisement for Big Pharma, basically. And this was, in fact, my next question as you raised the issue of medicine and pharmaceuticals, I should say. When we look at the American model of psychiatry, driven heavily by aggressive direct-to-consumer advertising, insurance-mandated rapid diagnosis codes, and the weaponization of the DSM, we'll get to that as well later, it has created an unprecedented landscape of overprescription. Now, obviously, in countries like Italy or the UK, it's not as severe. Your work, in fact, highlights how the disease-centered model serves as a massive commercial engine. How is this being handled in the UK currently?
So I would say the UK is probably one of the countries that has pushed back on these commercial incentives more than most other countries. These commercial influences. We have the NICE panel, the National Institute for Clinical Excellence, which evaluates it, which, as well as the drug regulator, evaluates the evidence as to whether it is worthwhile to publicly fund different treatments for different conditions. And so they scrutinize the evidence, and of course, they are influenced by mainstream thinking heavily, but NICE panels, which come to their decisions, include patient representatives and people from different disciplinary backgrounds. And so, for example, the NICE institution in the UK has refused to allow esketamine to be used to be publicly funded and available in the UK's National Health Service recently, on the basis that there was not enough evidence that this was beneficial and that it was a very costly treatment. So I think there are some political processes in the UK, political institutions, that help to push back to a certain extent against pharmaceutical influence, because Janssen, the makers of esketamine, were not at all pleased by that NICE decision and really pushed for NICE to overturn it, but NICE stood up and resisted that pressure. At least so far they have. And I think the other thing to say, and I don't know about the Italian system, I know all the European systems are different, but the National Health Service model, the publicly funded model of healthcare in the UK, I think mitigates against overtreatment to some extent, because it's not private practitioners or private organisations generally trying to acquire more patients and therefore more money. It's publicly funded people who are given a certain amount of money and then have to spread that out over everyone who has certain sorts of medical problems in their local area. So that, I think, helps reduce the incentive to overtreatment. But there is still, in my view, plenty of treatment for mental health problems that goes on that is inappropriate and not helpful, because it's all within this medical framework that, in my view, is fundamentally misunderstands the nature of the problems that it is purporting to help.
What role does the pharmaceutical industry play then in keeping the disease-centered model alive? Obviously, you've just discussed some of the responses in the UK. There have been others that NICE has patently turned down. How should we reframe our understanding of chemical imbalance if we have two decisions, the drug-centered and the disease-centered models, where clearly Big Pharma is going to push for one and not the other?
I mean, I think how to resist pharmaceutical industry pressure is really difficult, because, even though I would say that in terms of direct to clinician advertising and probably direct to consumer advertising in the US, the pharmaceutical, as far as psychiatric drugs are concerned, drugs for mental health problems, the pharmaceutical industry is a little bit less active than it used to be. I think partly because they've just completely saturated the market. I don't think there's necessarily many more people to pull in, although they are still advertising various products, of course. But I think the real problem lies in their control over the agenda. So, the pharmaceutical industry still funds the majority of pharmaceutical research. It can therefore, pharmaceutical funded public research is then, widely published. So the majority of papers that are published in journals are publications about pharmaceutical industry research, or are represent studies that are done by people who have links with the pharmaceutical industry. And just the volume of that research really helps to keep this whole idea of the disease-centered action of psychiatric drugs going. For example, there have been ideas recently, unbelievably, there have been ideas that opioid drugs might be helpful in depression. And so there have been papers published in the scientific literature on how depression might be caused by abnormalities in the endogenous opioid system. And those papers have been authored by authors who have strong links with pharmaceutical companies that are thinking about or developing opioid drugs for depression and other mental health conditions. So I think that's where the most pernicious influence is, that is most difficult to challenge. It's at that level of funding the research, setting the agenda, and filling the pages of scientific journals. So basically producing the scientific literature, which forms the knowledge base of the clinical specialty of psychiatry.
You're listening to Savage Minds. If you're enjoying the show, take a second to subscribe at savageminds.co. Feel free to comment below or drop us a line to share your thoughts. Support independent media today. Now, let's get back to it. Your historical analysis of psychiatry often exposes how the state and the medical establishment use psychiatric diagnoses to enforce social order and conformity. This directly mirrors everything I have read from Michel Foucault and his concept of biopower, the idea that modern states manage, regulate, and control populations not through physical violence today, but through subtle subjugation of bodies and the medicalization of normal human variation. So when we look at the mass prescription of SSRIs, again, I can finger point to the US very easily. Do you see modern psychopharmacology as the ultimate expression of Foucault's biopower? Even outside of the use of SSRIs, we can see it within the gender industry. We can certainly see it in other fields as well.
I agree with you. I think the use of pharmaceuticals for mental disorders or emotional and behavioral problems is a very good example of Foucault's idea of biopower. That idea has been developed by British social scientist Nicholas Rose, for example, quite extensively, who draws very, very much on Foucault. So I think that the mass prescription of antidepressants has helped to create this idea that we should all be happy all the time. And Foucault's got this idea that there are all these subtle ways in which that power can be exerted in these subtle ways of telling people what sort of people they ought to be. It's not necessarily just the repressive, putting on the straitjacket in the asylum. It is also telling people, you need to be a happy, chirpy, productive person 100% of the time. And I very much think that the mass prescription of antidepressants is feeding into that. So my impression in the UK at the moment, among younger people in particular, is that there is this idea of, why shouldn't I be on an antidepressant? That, if I'm not on an antidepressant, I'm really sort of letting myself down in some way because I'm not going to be as happy and productive person as I can possibly be, which of course is completely at odds with all the research that shows not only that antidepressants are not very and probably not at all effective in lifting people's mood, but certainly doesn't show that they make people any more productive, and quite possibly with all the lethargy they induce and fogginess make people less productive. But anyway, I think there is that perception out there in the population that that's what they do, and that therefore you really ought to be taking them unless there's some very good reason why you can't. And I don't want to go into the gender area because I'm not well acquainted enough with the literature, but I'm sure there are some parallels particularly in this, in the creation of this idea that we should all, aspire to be perfectly happy, perfectly comfortable, perfectly comfortable in our own skin all the time, and therefore obscuring the fact that human life is full of challenges and full of difficulties, and that human development and one's life history is very much about getting to grips with those difficulties and learning to overcome them in one way or another. But that's not a simple process, and it's certainly not a process of taking a pill and finding that suddenly everything's all right.
Indeed, I completely agree with you. In fact, I've been on the other end of this situation, as I'm not a psychiatrist. In 2007, I lost my first child. He was 7 weeks old, cot death. And I was told by my head of department at the Université de Montréal to take sick leave for the fall. And I didn't want to, but I thought, he probably has a point. I should probably deal with mourning. But in order to have the sick leave, I had to be signed off, not by a psychologist. I even asked, I had to go to a psychiatrist. So I went to the psychiatrist, I wait in the hallway. She calls me in. I explained that my son had just died the week before, And I said, one thing I want to be clear about is I do not want any medication, no drugs. And she looked at me and she said, c'est moi qui décide. It's me who decides. I was shocked by her answer because this was morning. But as I looked into this, because on my leave, I actually went to London, my first time living in London, and I did research at the Wellcome Centre Library. And I started to look into the history both of cot death and mourning of childhood loss. And it was very interesting for me to learn, because I did not know this. This is still the case, as I found with my psychiatrist, that mourning is sometimes looked at as a psychiatric condition by people who have motives, either, I don't know what their training was, or they are pro the, let's call it the pharmaceutical model. But this all shocked me quite a bit. I was insistent, and she did not prescribe me anything because I kept having to state over and over, mourning is not depression, might look the same, but it's not. Is there a tendency today, even within psychiatry, not just the case of mourning, but to deal with issues through pharmaceuticals or to treat it as a mental illness? You've just referred to something I'm very critical of myself. Why do we have to be happy all the time? Maybe the reason why there's so much depression is because people are taking these drugs and not learning to cope with life's circumstances. What happens for good, bad, and the boring?
So first of all, I'm really sorry. What a terrible thing to happen. So I also have a close friend who lost a son when he was an adult, and she was also prescribed antidepressants by her GP. She didn't have the energy to challenge the GP, so she just threw them down the toilet without taking them. And although bereavement is meant to be an exclusion from being diagnosed as depressed, in my experience, people are very often offered antidepressants and therefore implicitly pathologized during the process of grieving. That's partly, I think, because I think that's an indication of how, of the medical nature of our system, of how we don't have anywhere else for people to go if they are suffering and struggling with something, whether that's a mourning process or whatever it is. And as you said, how we don't have another system for giving people time to mourn, to mourn properly, for giving people time out of their responsibilities, including their work responsibilities, to recover from an event like that. And I also want to say that I think a lot of depression is mourning. And it may not be mourning the death of someone, but it can be mourning the loss of a relationship, the loss of relationships and social contact in general as one gets older, the loss of a job, or it is often, I would say, not always, of course, but often a reaction to losses of one sort or another, which are not. So yeah, I think that's a really good example of how ridiculous it is to medicalize these situations.
Well, there's a funny side to the end of this story, because when I was pregnant with my daughter in 2012, the Children's Hospital in Montreal, I remained in contact with the SID Center. And the nurse who helped me through the morning, I would go there every day, then twice a week, then twice every month, and so forth. She kept in touch with me over the years. And she said, now that you're pregnant again, I mean, this isn't going to happen again. It's statistically, very unlikely. But just so that you can sleep, you should contact the Whittington Hospital, and they have an adapter that you attach to your child so that when you sleep, should they stop breathing, a beeper goes off on the device. I did so. The nurse came to my home. She interviewed me, asked me about what happened, my experience of my son's death. I told her. Paradoxically, I was moved from the McGill Children's Hospital over to my nearby, quote unquote, adult hospital because they have every parent who loses a child within the Canadian system see a psychiatrist. She did not try to give me antidepressants. She did give me 40 sleeping pills, which, as a scholar of Middle East studies, I took it as a 40 days of mourning in Islam, right? So I thought, okay, this is a sign. I had worked on my previous book on this, so I thought it was a sign. I wasn't thinking quite clearly. But in waiting for her for many hours, a colleague of mine and I were in the mental ward. They literally took my bag, my belt, like, what am I going to do? Kill myself in the waiting room? But whatever. They did this. And so I'm telling the nurse about this very bizarre story about, again, this repeats what I had just explained earlier about this kind of mourning being treated as a mental health issue, a psychiatric issue, when the role of the psychiatrist, who was really cool, was just to give me sleeping pills, basically. Okay. But this came back later to bite me in the arse, as one would say. While I was living in central London, I had just given birth. The health visitor came. I said, no, thank you very much. Been there, done that. I have all the bulletins about the vaccination schedule. Thank you. She didn't like that. And somehow the Whittington nurse and her spoke. Next thing you know, I kid you not, had a social worker asking me about my stay in a mental hospital. I'm not even making this up. The long story short of this is I actually eventually got an apology from the Whittington Hospital, but this speaks to how there's this kind of vector placed over women, especially I'm a single mother by choice, who fit this paradigm, but a paradigm that gossip led to, because there was no, I explained the story clearly, and I was in fact speaking about how my colleague and I were joking because we shared students sometimes, and I said, if they ever ask me how I met you, I'll say we met in the mental hospital ward. I was making light of it because it was quite surreal to have 10 hours earlier lost a child and you're sitting waiting for a psychiatrist to come in.
Yes, it's just extraordinary, isn't it? And it just illustrates everything that's wrong with our current approach. That we can't imagine any other way of helping people other than medicalising them and saying they've got a mental illness, even in that situation where everyone, absolutely everyone, would be extremely distressed.
Exactly. In fact, all of that I can laugh at now, thankfully. But I think, my own father, he was given lithium for depression. He was in a mental hospital after my parents' divorce. It's a no-brainer what his depression was about. And I'm just wondering that today, given the knowledge that we have, especially thanks to people like you, if we completely dismantle the biological model of mental illness, what does a successful day-to-day psychiatric practice look like?
Well, I think we need to, coming at it from the other point of view of how to help people, I think that people with common emotional problems that we would today diagnose as anxiety or depression need to be, people with those problems need to be supported outside of medical institutions. I would suggest that we could set up services in social services, and that would be sensible, because that would then enable people to focus on the social circumstances that were causing them to be depressed or anxious, and to get appropriate help for their individual circumstances. So that's how I think mental health services should be organised. Of course, for people who have more, what we might call more severe mental health problems that are currently diagnosed with schizophrenia or mania or bipolar disorder or something like that, I think that some people do need institutional care from time to time, some people who have those difficulties. And I do think that there is a role for some drug treatment in suppressing the symptoms in one way or another, the old chemical restraints. But obviously these should be administered as minimally as possible, and their use should be scrutinised properly, and the interests of different parties, including the patient or the person that these drugs are being given to, should be probably taken into consideration. So there is a role there for people who have medical qualifications, particularly knowledge of drug treatments and pharmaceutical interventions. Although I would say that our current training on medical students and doctors' current training on the nature of these drugs, what they do, what their long-term effects are, how they change the brain, how they change the body, is woefully inadequate at the moment, because it's so focused on this disease-centered model, so that all anyone is interested in teaching or learning is, what receptors these drugs supposedly target that cause them to work.
How do you view the rise of psychedelic-assisted therapy? Is this a genuine shift or just the next wave of biological psychiatry?
So initially, the idea of psychedelic-assisted psychotherapy is that the psychedelic experience that is induced by a psychedelic drug might be able to give people interesting insights into themselves and their lives that might help them moving forward in managing some of their mental or emotional difficulties. I think that's probably rather optimistic, given that, most people who are significantly depressed or anxious are dealing with difficult circumstances. I think it's difficult circumstances, or, maybe patterns of behaviour that they've got into over many years. So I think it's rather optimistic to think that those are going to be drastically altered by one or two psychedelic experiences, even if you thoroughly reflect on them. But nevertheless, it was what I would call a drug-centered model, in that it acknowledges that these are drug-induced experiences. It's not suggesting that the drugs are targeting some underlying abnormality. It's acknowledging the drug-induced experience and trying to make use of that. And I think you can apply that to other drugs as well. I mean, I think I've had patients when I worked in addictions, for example, who had problems with alcohol, and who said that one of the reasons they'd had problems with alcohol is that alcohol helped them to be sociable and helped them to interact with other people. They were maybe particularly anxious, socially anxious or shy. And some of those people managed to stop alcohol and then managed to take what they'd learnt under the influence of alcohol into their now sober lives, so that they could become more sociable without alcohol, even after they'd stopped it. So I think we can sometimes learn things from drug-induced experiences, and that's what the whole principle of psychedelic-assisted psychotherapy is, or at least started out as. I think the problem is that it's not readily commercializable, if that's a word. Having one or two psychedelic experiences with a lot of psychotherapy is quite an expensive process, and if you're just doing it once or twice, it's not going to generate a lot of profit or income for companies that are administering this sort of therapy. And therefore, I think that it inevitably tends towards a model of people undergoing long-term treatment with actually little psychotherapy, and then this idea that what the drug is doing is actually correcting some underlying disease or abnormality creeps in and replaces the idea that it was the psychedelic experience that was important. So, for example, if you look at the experience of ketamine treatment in the US, it started off as ketamine-assisted psychotherapy, with the idea that people would have one or two treatments, and that might somehow sort of change their mindset and help them to process things, and that treatment should be supported by psychotherapy to enable people to do that effectively. It has turned into people having long-term, regular ketamine injections without psychotherapy in most circumstances, and with the idea that what the ketamine is doing is resetting some glutamate abnormality or problem with neuroplasticity or neurodegeneration processes. So it's it's come to look much more like a model of long-term antidepressant treatment. And of course, esketamine was always set up on that premise anyway. It was set up as a long-term treatment, evaluated as a long-term treatment, as the idea that people would come and get a couple of esketamine sessions every week for weeks on end. So I think, I'm afraid, because money has got involved, because lots of private organisations are trying to set up psychedelic treatment facilities, and they need a base of returning customers who come back week in, week out for more treatment, I'm afraid it will just become the latest biological fix to this mythical idea of some underlying chemical imbalance or biological abnormality.
Yes, this seems to indicate to me, from everything I've read and what you're saying now, that there seems to be this kind of stress and pull between even patients and the psychiatric community, the specialists, I should say, because we have been inculcated into this belief as well through pop culture, music, TV shows, where this is the fix. And I can tell you that in other fields, I've interviewed Simon Wesley and his work on CFS, and the pushback he has received for simply being a vocal defender of cognitive behavioral therapy and graded exercise therapy. When I published that piece, it was pulled within an hour. My editor didn't even ask me, because that's how much pushback they got. They got severe pushback. Because you can't even talk about Wesley. He still apparently has to have his mail scanned in a machine, an X-ray machine, and for any kind of explosive devices. And when I worked on that piece and the follow-up, I was alarmed to see the way in which even the DSM has been politicized, including around gender, and the way that patients have become activist organizations, and they push upon either the institutions of certain professions, be it medicine or psychiatry, and the way that they pose themselves as a threat to the status quo. So it's not surprising that psychedelic therapies have risen, because there's such a core aspect of this, which is the patient is always right, the customer is always right, or the customer is king, I guess, from the US. And this is filtered into medicine, including here in Italy. Could you talk a bit about this kind of stress and pull that's going on between let's say, the group of patients and then psychiatric specialists themselves?
So I think this is a very complicated area. I think that overall it is a very good thing that patients have more of a voice and more influence over the debate or debates within medicine, and over what medicine looks like, what is offered to people. I mean, for example, in the field of chronic fatigue, I would have probably been in Simon Wesley's camp quite a few years ago, and feeling that the majority of this was a psychological problem and should be treated with CBT. I've had long COVID myself over the last few years, and I have experienced how annoying it is to be told by people that it's all in your head, and for it to be suggested when you're feeling extremely tired that you should go on a graded exercise program. So I've seen directly where that anger and frustration has come from, and there's something similar going on in the population of people who have protracted antidepressant withdrawal and persistent sexual dysfunction after taking antidepressants. There are some clinicians who are telling them that this is all in their heads, that this is essentially a psychological problem, a resurfacing of their original problems or some sort of new problem, and basically not believing that this is physical condition that has been caused by brain damage to the brain caused by taking these drugs for a long time. So I think all that is, understandable. And that's not to say that, of course, for any medical condition, any condition at all, there are always, some people whose fundamental problems are psychological, but they're experiencing their psychological problems through physical symptoms. That always happens in some cases, but that doesn't mean that these syndromes are not real physical syndromes as well. But then there are patients who, there are many people who have become extremely attached to the medical model of mental health problems. And I saw that after the publication of our serotonin paper, as well as the reaction from professionals. There was a reaction from some patients who'd been taking antidepressants for a long time, who were very angry that we had published research that somehow undermined the identity that they had come to adopt, that they were chemically impaired or deficient people in some way who needed to take a drug to rectify that impairment. I think that's really sad. I think it's really sad that there are many people who've bought so heavily into this medical model, who've come to believe that they are biologically defective in some way, and that they need a medical treatment to make them normal. But I can completely understand that if you've come to that view, especially if, for example, you didn't think of that didn't think of yourself in that way in the first place, but you've been gradually persuaded by all the information out there that that's what you're really like. And then someone comes along and says, actually, that information was all wrong. There's no basis for this. I can see that that is a really disconcerting position to be in. So there are some people who push back in that way, who have come to define themselves in this medical way as having this a medical condition, and therefore perceive any debate about that as a challenge to their identity.
As an anthropologist, I totally understand what you've said, and I agree with it. At the same time, I have some concerns about the kind of politicization that has gone around one's medical identity. While I understand it's very important, you mentioned Bersalia, that was a most important step to take, which influenced mental health systems around the planet. I think it's very important to be active in your own healthcare, and when you identify needs of reform, sure. But my concern is in a way that we've become a society of identifying ourselves indelibly, permanently with X condition, where X condition could be any, might not be that hard science. And there seems to be this intractability to understand that maybe something else is at play. Yeah. So I'm just wondering your thoughts on that, in terms of what advice as well would you have for the next generation of psychiatrists who want to practice critically and ethically while understanding these very issues?
So I think you've articulated a really important problem that's going on at the moment, which is that many people are coming to understand various difficulties that they have in life in the framework of having a diagnosis and having a medical problem. And by doing that, they are labeling themselves as being permanently impaired. And I'm thinking particularly of diagnoses like ADHD and autism spectrum disorder, which many people are now coming to mental health services in the UK and asking for. They are actively seeking these diagnoses. They have decided that long before they get to see a psychiatrist, they've decided that these diagnoses must explain their difficulties. And I think there's a lack of understanding about what the diagnosis actually is, which has partly been promoted by psychiatry and the current mental health system, and manuals like the Diagnostic and Statistical Manual, so that people have come to think that getting a diagnosis of ADHD or autism, for example, means that they have an explanation. It means that they've now been shown to have some problem in their brain, or some process in their brain, because it doesn't necessarily need to be regarded as a problem, but some process in their brain that makes them different and explains why they behave in a certain way. And what they don't realize is that, a diagnosis of ADHD or autism, in fact, no mental health diagnosis shows that at all. No mental health diagnosis has been definitively linked with any brain process. And all these diagnoses are descriptions of certain sets of problems. So all that happens when someone comes and gets the diagnosis of ADHD is that a doctor rubber stamps their description of their problems with this particular label. And as you say, I think that can be really unhelpful. I think it can, it shapes people's identity. It makes people believe that they're going to be permanently impaired. And therefore, it makes people restrict their horizons and their aspirations. Oh, I'm not going to be able to do that because I have ADHD or I have ASD. Oh, I can't do this, I can't do that because I'm ADHD, because I'm whatever. So I think this is a really worrying trend, and it's difficult to know how to challenge it. And I think one of the ways that it will eventually come to an end is there will be a scandal about the overprescribing of stimulants, and a realization that long-term stimulant use is not side effect free, is associated with lots of difficulties and problems and some harmful effects on the heart and the brain and things like that. So I think that's one way that it will come to an end. What would I say to the next generation of critical psychiatrists? Really keep your minds open. I think it is possible to practice in a way that is consistent with critical psychiatry values, by making sure that you inform patients before prescribing for them about the drug-centered model and the likely effects and complications of taking different substances. I think it's perfectly possible to have discussions with people about the meaning of an ADHD or an autism diagnosis. Some people don't like those discussions. They don't want to hear that sort of thing, but I think it's very important that people are informed about what the diagnosis actually means and what it doesn't mean. And that it doesn't mean that they have a brain impairment or defect that consigns them to a life of limitation.